The biggest problem with the first generation of stem cells that are still being used in practice today is that they get cleared up by the immune system relatively quickly. And the other big issue, because it's such a big country, the FDA just can't keep track of all the clinics, all the stem cell clinics. None of them are offering real stem cells. They're offering what are called committed progenitor cells. They're taking bone marrow or they're taking fat, and then they're just centrifuging or spinning it, and then they're injecting it back in, and they're telling people these are stem cells. But unless you isolate the actual mesenchymal stem cell and culture expand it, it's not a true stem cell.
All right, Dr. Adeel Khan, I am thrilled to welcome you to the Better podcast. Welcome to the show.
Thanks for having me, my fellow Canadian.
Yes, we have to do some, get into our oot and a boot or our little funny accents that people often tease us about. But yes, my fellow Canadian, I think you're in the same province, or maybe you practice in Ontario as well as I. And I am so happy to be having this conversation with you around generally, anti-aging and longevity. But I know that there's a lot of different possible tentacles that we can talk about in terms of stem cell therapy, which is your specialty. So I thought we might start our conversation just with some definitions, because I think stem cells, that can mean a lot of different things. So let's maybe start with the embryonic. When I gave birth to my two children, we kept the stem cells from the umbilical cord. They're somewhere in some freezer somewhere. Maybe we can talk about the different types of stem cells and why that's important. So I've heard you talk about totipotent, pluripotent cells. So maybe we can just have some definitions for the listener.
Yeah, I think the way I'm finding to simplify things is what's available to the public and what they see, and then kind of like the scientific textbook stuff. Because the scientific definitions aren't super helpful for the average person, but just I'll explain it generally. It's essentially there's totipotent, there's pluripotent, and those are kind of the two big categories of stem cells that we use in practice. But the problem with totipotent, so totipotent means the cell can turn into anything, which includes it could even turn into placenta or umbilical cord, is before that stage. It hasn't differentiated into anything yet. And so, yes, in theory, you would think embryonic is the best because we can turn it into anything. But then there's, of course, ethical issues. Where do we get them from? Do we source them from fetuses? And that's where this whole debate happened in the Bush era. And that's why stem cells became controversial. And there were some clinics actually in Ukraine and other places offering embryonic. And I think there are still some, and even in India and stuff. But you got to be really careful, because embryonic, because it can turn into anything, and because it has so much stemness, which means the ability to turn into different types of tissue and differentiate, and also the ability to divide. So it has too much stemness, it can turn into tumors. And so you always have that risk with embryonic stem cells. And so embryonic stem cells never really took off clinically. They took off for research purposes, but I think clinical application of them is still not going to be the best source, and it's not going to be the way of the future, in my opinion. What I think is going to be the way of the future are mesenchymal stem cells and induced pluripotent stem cells, which we'll go into. Mesenchymal stem cells are pluripotent. So that means they can turn into the three germ layers like ectoderm, mesoderm, endoderm, but they can't turn into placenta or umbilical cord, obviously, because they're already differentiated one line further, so to speak. And so, but the good thing about mesenchymal stem cells, or stromal cells is technically the more technical word, but we'll just say stem cells because that's what everyone uses now. And it's basically the ability to divide in a finite amount. So meaning it won't keep on growing or replicating uncontrollably. So you don't have that risk of tumors. And the other thing is sourcing. Mesenchymal stem cells obviously are easier to source because umbilical cord tissue is pretty ubiquitous after C-section births. It's easy to collect, and you can do it in a sterile way. And then the other thing is you can also get mesenchymal stem cells from fat, from bone marrow, dental pulp, from menstrual blood. There's all sorts of sources that
I've seen that now, that they're collecting menstrual blood you can also do a lot of biomarkers, and you can also be evaluating, markers of inflammation and other markers through the menstrual blood. But that was something that I also saw, was that they can also look at some of the stem cells there too, which is cool.
Yeah, exactly. So it's pretty ubiquitous in the body. And the key is, though, you have to isolate them and you have to really do what's called manufacturing of these stem cells. And this manufacturing is kind of the nuanced detail, because stem cells have been around for a long time, and there's some clinics that have been offering them for over 10 years, but it's really the manufacturing process in the last couple of years has improved to a point where we can control what the cell is doing. And that cell standardization is still kind of the biggest problem we're trying to solve. And it still hasn't been solved, but we're getting close, and we can at least reproducibly get some good results now. But I think the big issue with umbilical cord stem cells is the donor heterogeneity and the heterogeneity you get in terms of responses. And so what we want to try to do is we want to create what's called immortal cell lines that have one donor, like a super donor, and then we can reprogram these cells and we can make them do what we want. So that's kind of the future of where stem cell therapy is headed. And that's what's called induced pluripotent stem cells, or iPSCs. And that's kind of where you reprogram a skin cell or any somatic cell in your body. You could take a muscle cell, a fat cell, and you can press a reset button on it, which I love that analogy because it's basically taking it back to a baby stem cell state. So it's embryonic in nature, and then you can differentiate it into a mesenchymal stem cell or a beta islet cell or a neuroprogenitor cell or whatever you like. And then this is called iPSC-derived MSCs, or iPSC-derived neuroprogenitor cells. So you can create all these different cell lines, and it turns out iPSCs have a much higher potential for engraftment, which is true regeneration. And then you can also control and gene edit them in different ways to manufacture them to get what your desired purpose is. So that's called cellular engineering and synthetic biology, and that's kind of the field I'm very immersed in now.
Do we have to have, in the same way that if you were looking for a bone marrow donor, you have to have the right antigen, you have to, if you're doing a blood transfusion, there has to be sort of that immunogenic match. Do we see that with stem cells, or is that not necessary?
So mesenchymal stem cells do have low expression of HLA antigen. So it's so low that it's immunoprivileged, meaning it's not going to cause graft versus host disease. But because there is still a low expression, that means they're still immunogenic. And this is the biggest problem with the first generation of stem cells that are still being used in practice today, is that they get cleared up by the immune system relatively quickly. And so they're not staying in your body for months, or they're not permanently engrafting. Most of them are getting cleared up by the immune system. A lot of them don't end up surviving. But you're still getting what's called paracrine signaling. So you're getting signaling and immunomodulation of the environment that you're putting them in. And hence why even first generation stem cells can have some pretty dramatic effects for autoimmune conditions, for chronic inflammation, for osteoarthritis. But it's really preparing the microenvironment and the environment you're putting it into to ensure that the cells can do what they need to do. So that's really the key nuance, I would say, when it comes to using these first generation umbilical cord derived mesenchymal stem cells. And the other big issue, which is more so in the US, because Canada's kind of really, because Canada's a smaller country, so it's easier to manage. But US, because it's such a big country, the FDA just can't keep track of all the clinics, all the stem cell clinics, but none of them are offering real stem cells. They're offering what are called committed progenitor cells. They're taking bone marrow or they're taking fat, and then they're just centrifuging or spinning it, and then they're injecting it back in, and they're telling people these are stem cells. But unless you isolate the actual mesenchymal stem cell and culture expand it, it's not a true stem cell.
So the stromal cells, can't you derive those from like dental pulp and fat and bone marrow?
You can, but you have to take them and then you have to culture expand them, which is illegal in the US.
You have to culture and expand them. Mm-hmm. That is illegal.
If for clinical applications, unless you have an IND or clinical trial.
Okay, and why is it illegal?
Well, that's a
I know that's like the $1 million question, right?
Yeah, that could be a whole podcast. But the short of it is the FDA has a revolving door between CDC, the big pharma companies, and the people who work are often tied to one another. And so it's probably in their best interest for these therapies not to take off, because they can really disrupt the traditional model, especially orthopedics, which is probably one of the biggest revenue generators for hospitals. And osteoarthritis, as I'm sure everyone knows, is an epidemic, not only because of aging, but because of everything, the environment we live in, the processed foods, the limited exercise people do. And so you're just getting such a high prevalence of these joint replacements and surgeries that are probably A, preventable, and that's not being done. And then B, there's other options that are less invasive and just as efficacious, if not more efficacious, such as stem cell injections, which are not being approved and not being allowed because they're going to disrupt an entire industry. And if people are really curious to dive deep into that, you can look up Dr. John Abrahamson. He's from Harvard, and he has a podcast with Lex Friedman, and he wrote a book called Sickening, which is essentially a whole book about the corrupt pharmaceutical industry and how it kind of controls the narrative in mainstream North American medicine. And it's not just me saying it. I've traveled the world. I've been fortunate to work in many places, and obviously, forget South America, but I think about like Japan. I always like to bring up Japan because they're such a great developed country, and they have technologically they're advanced in so many ways, and they've been doing culture expanded stem cells for almost 10 years, and they have a regulatory framework. Instead of just banning it, they regulate it and they allow certain people to do it under certain protocols. So that to me is a way forward, but they've kind of just taken a blanket approach, which is they're saying that stem cells are like a drug, and therefore you cannot use them unless you have a specific drug approval. And they're just trying to make the matter more complicated than it has to be.
Yeah, that is a separate conversation, but certainly as a doctor of chiropractic, I understand very, very intimately. And, if you just look at the history of chiropractic in the US, certainly, and there's an element of job protection sort of that's happening there. So anytime whether it's an industry like chiropractic or stem cells like we're talking about encroach on sort of the standard, there is typically a tendency to sort of rip it apart, which is where the word quack comes from. Actually, there's
well, I actually like one of the analogies one of my older mentors talked to me about was endovascular stents. When they first started taking off and replacing CABG, which is open heart surgery, basically, they called the people who were doing the stents quacks, and they called them and they said, "Oh, this is dangerous. You shouldn't be doing this." And stents are so much safer and less invasive and way better and life-saving now, right? They're the standard of care. But that was like he said that was like a 15, 20-year battle, right? It took time. So that's the same battle we're having now. And it's going to happen. It's just, we're in that beginning phase.
Okay. So let's talk a little bit more about these mesenchymal cells. I know that you've talked about Yamanaka cells. My understanding of these Yamanaka factors is that we've had David Sinclair on the show, and he was talking about how you basically take off all the methyl groups until the cell no longer has any methyl groups. It's like you're just basically reverting it to its original form. Can you explain what that is, or redirect me if I'm incorrect?
No, that's completely right. All it is it's these 4 transcription factors, when overexpressed, change the epigenetic age or the epigenetic alterations back and essentially make it naked again. But it does still have a memory of what it was. So it tends to differentiate into that. It tends to want to, like, for example, if you take a skin cell and reprogram it back to an embryonic stem cell, that embryonic stem cell still has a memory in it that it was a skin cell at some point. So it has a tendency to want to turn into that cell lineage, but you can kind of code it in a way and program it to go into whatever lineage you want. But it can be difficult. For example, you can create beta islet cells, which are insulin producing cells that you can be transplanted into the pancreas to create new insulin producing cells and actually treat diabetes. And they've done a group called Vertex has done that successfully in clinical trial.
For type 1 diabetes.
For type 1 diabetes,
yeah. Okay.
Yeah, and so, but to create those beta islet cells, it has to go through like 8 steps, and it's a very complicated way to do it, and it's a process. So it's not easy, but it is doable. And the issue with embryonic or with the Yamanaka stem cells is, like we talked about earlier, when you have embryonic, again, you can cause tumors, right? And so and that's why iPSCs, people were hesitant to use them, and there are still people doing iPSC approved trials without really considering the fact that there is still at least a 1% chance of those cells turning into tumors and eventually having uncontrolled growth. So the technology we're developing, or we already have developed, but we're differentiating into different cell lines. Our iPSCs have a gene edit to prevent uncontrolled proliferation. So if it starts dividing uncontrollably, it has a kill switch, and then it'll stop the cell from dividing and proliferating. So that's the key difference. And then the other cool thing with these, if you think about it from an aging perspective, what we can do eventually is we can take those Yamanaka factors and then we can apply them to different areas in the body through a gene therapy that we have and de-age your body in different ways as well. So that's something in the future that we want to work on too. And we've had David Sinclair obviously would be a great person to talk to that more about, and we've had a few conversations. But it's a great technology, because I think reversing your body through this Yamanaka technology holds so much potential.
Yeah, I think when I had him on the show, he had just shown regeneration of the optic nerve, and we'll talk about vectors in a moment, but I think that the vector was a viral vector. If I remember correctly, it might have been like the adenovirus. I forget which one it was.
AAV, adeno-associated virus. Yeah.
Yeah.
And the problem with viral vectors is the fact that you often have to go on immunosuppressants, or viral vectors also are not reversible. And then there's always a risk that they could translocate, and then you can cause obviously other, infection or other associated consequences of that.
Well, gee, I don't know what you're talking about. We've only seen that en masse over the past 4 years of COVID. Yeah. Okay. Actually, I want to come back to that, but you said some of we were talking about aging. So I just want to double click on aging for a moment, and then I will, hopefully we can come back to big bad viruses with spike proteins and maybe some of the problems around the mechanism of delivery. So some of the primary, I think there's maybe 12 now, 10, 12 hallmarks of aging. Some of the primary ones, of course, are like telomere shortening, genomic instability, loss of proteostasis. So how can we be thinking about stem cells, and especially using these Yamanaka stem cells or Yamanaka factors to be reversing? And I know that there's others, I've just mentioned a few, but what is the mechanism of action there? So if we're taking stem cells to help with genomic instability or the telomere shortening, et cetera, what is going on there?
Yeah, so there's two things. One is that if you look at the latest theories on aging, a lot of them are coming to this idea of unitary theory of aging, which is essentially like oxidative stress and chronic inflammation are probably the root cause. And where is that coming from? It's potentially coming from mitochondrial dysfunction. So if they've done studies, for example, where if you look at a 5-year-old, they have 0% mitochondrial dysfunction. And then if you look at a 75-year-old, they have 95% mitochondrial dysfunction. And so why is the mitochondria so important? It's because it's not just for energy production, but it's for regulation of your immune system, of what are called reactive oxygen species, and these metabolites that get made from mitochondrial dysfunction over time that over time cause cell dysfunction. So these metabolites these different things that are being made from the mitochondrial dysfunction that are through the process of them becoming dysfunctional are eventually causing the cell to become dysfunctional. So the root cause is that mitochondrial dysfunction, and that's where mesenchymal stem cells have been shown to help with mitochondrial health. And there's recent papers coming out about the mechanism of how there's actually mitochondrial transfer from the stem cells that you're putting into the body and helping to restore mitochondrial dysfunction. So I think from the root level, I always think about, okay, we're trying to restore mitochondrial health. And then the other big thing we're doing is immunomodulation, which is we're reducing chronic inflammation and we're shifting it's called macrophage phenotyping. So you're shifting from what's called M1 to M2. It's polarization. And it's what that means is the cytokines that are being released are not going to be pro-inflammatory. And the reason I'm talking, because I know you asked about proteostasis, but when you affect these two biggest things, everything else gets affected because they're all intertwined to oxidative stress and chronic inflammation. That's the root of kind of like the pyramid. And then everything from there gets affected. The latest papers that I've been reading about this, the theory is that because of these two, and everything else is kind of intertwined to those two. So if we can get to the root of the issue, it'd be those two. And that's why the stem cells are so effective for anti-aging, because of the fact that they're targeting that chronic inflammatory process and oxidative stress and restoring mitochondrial health. But having said that, I think the biggest problem with umbilical cord stem cells, as we were talking about, is we can't get them to stay there as long as we want. They're only staying there for a few weeks. So we can't really, ideally they would be there for a longer period of time. So our cell line that we're working on that should be ready later this year, we're genetically engineering MSCs, the Yamanaka ones, to do what's called anti-interleukin beta. So they're going to express anti-interleukin beta to target the inflammasome. And the reason is because the inflammasome, which is the NLRP3 pathway, is essentially, if not the most important pathway in aging because of the chronic inflammation and everything that ensues from there.
You mentioned mitochondrial transfer. I don't think I've ever heard that term. Can you explain to me what you meant by that?
So the mesenchymal stem cells are actually, so to speak, donating their mitochondria, that the healthy mitochondria, and transferring it to the unhealthy cells.
So is there like an is there like there's cell death of the old mitochondria, or they're just doing like a bit of a swap, like you go to a,
No,
like
it's exactly, no, they're triggering mitophagy.
the triggering mitophagy. Okay, okay.
Yeah.
All right. So that's okay. So that's very cool. And aging, even though we have all of these different, I had someone on the show, I was recording with her just last week, and she was talking about the peptide theory of aging. There's all these different theories of aging. And really, if you boil it down to, I love what you're saying about this sort of unitary theory of aging. It's just entropy. Like there's just more and more and more. It's like you try to keep your bedroom clean, and eventually the closet gets messy and the bed gets unmade, and like just things kind of get out of source from each other. I mean, that's a very simple example, but just to give
no, exactly. But like your closet door is like your mitochondria. So
right.
Eventually you just it can't deal with all the crap. There's too many oxygen species, there's too many metabolites, and then over time the mitochondria don't, even senescence is most likely related to mitochondrial dysfunction, because the signal for senescence is reactive oxygen species over time accumulating. And so instead of the cells going through autophagy like they should, they don't, because of the mitochondria becoming dysfunctional.
Okay, so let's talk about this from a clinical lens. So this is like the geek and nerd in me absolutely loves this conversation. And I would like to also extract it to have some clinical application for our listeners. So a lot of the people that listen to the show typically are perimenopausal, menopausal. The things that were working for them in their 20s no longer working for them in their 40s or 50s. Mm-hmm. There's an accumulation of ectopic, they have like ectopic fat distribution where they're starting to see more of that fat sort of centrally versus, if you're a woman, you typically, under the influence of estrogen, tend to deposit fat, let's say in the hips, in the butt, lower stomach, that kind of thing. And then we see this sort of wildly vacillating levels of estrogen through our 40s, and then the eventual sort of fall off a cliff, through menopause. And progesterone is included, and testosterone is included in there as well. So maybe we'll just start with hormones. I do want to talk about a couple of other, you mentioned autoimmunity. Certainly women deal with things like Hashimoto's thyroiditis at levels, orders of magnitude much larger than our male counterparts do. And then osteoarthritis, frozen shoulder, very common in females, 40s and 50s. And I certainly clinically have seen that almost ad nauseum, really. So let's talk a little bit about hormones and how, we know that prior to menopause, it is the ovary, in females anyway, it's the ovary that's primarily making our sex hormones. How can we potentially utilize some of these stem cell therapies and gene editing technologies that you're developing to support, augment ovarian function?
Yeah, the person I learned from on this is Victoria Felker. She's a fantastic scientist on fertility, and she has done a lot of work into the root causes of infertility and also of hormonal issues and women aging specifically. And so, not shockingly, it's actually the same root cause. So the ovaries are just like any other cell in your body. They get mitochondrial dysfunction. They get the chronic inflammation. They get all the same hallmarks of aging, and the ovaries age too. So the question is basically, how can we de-age the ovaries?
The oocyte, maybe. Yeah.
And we can do that pretty reliably when we do what are called intra-arterial ovarian injections with stem cells and exosomes, because they're targeting those hallmarks of aging like we talked about earlier. And then we also can do systemic treatments to de-age the whole body. And so that's our follostatin gene therapy, for example. That's a plasmid gene therapy. It's essentially, when people think of gene therapy, they get kind of scared. They're like, are you modifying my genetics? Are you changing my genome?
Is this a COVID vaccine? What is this?
Yes, COVID vaccine. No, it's much safer than that, actually.
Yeah.
So the beauty of this plasmid vector is it's just a delivery mechanism for your cells to make more follistatin. And so follistatin is actually highest when you're pregnant. And so why is it high when you're pregnant? Because it's actually an anti-inflammatory kind of protective peptide. It's naturally occurring in your body, but as you get older, the levels decrease. And so we're kind of just restoring them to an optimal level through this injection, but it also de-ages your entire body anywhere from 5 to some people were like 20 years based off intrinsic biological age and epigenetic reduction.
What are you measuring there? Sorry to interrupt you, but what are you measuring there to
true age
quantify the 5?
We use their technology for that clinical trial that we did, which is a true age diagnostic, is essentially looking at inflammation is probably the biggest one to look at a DNA methylation of CRP. And then, so that's the one that we use for the trial. However, on your point about entropy, you're probably on the right track, because I think the best aging test now, from what I'm reading, is called Generation Lab, and they use biological noise, which basically measures like entropy in the body and different organ systems. Noise. So I think that's the one we're going to use for our second clinical trial, which is starting later this year. But back to the point, basically, when you de-age your body, and restore your ovaries to a younger age, essentially, then you're going to get better hormonal production. It's because it's the same underlying processes that are causing the ovaries to age and to not be able to do what they used to do.
And does that extend your fertile years then? Would that extend your
we've had patients. Obviously, we need to do more trials, but I can tell you anecdotally that we've had patients who were unsuccessful with IVF, with trying everything, and then we did the stem cells, and then they were able to get pregnant. And that's just because, what's the mechanism there? It's the same thing. It's basically targeting those hallmarks and getting the ovaries to start working again and regulating their cycles and producing the estrogen and everything.
That's an it's an interesting thought experiment in a way, because on the one hand, certainly for if you are, let's say 30 or 35, 40, 45, and you've been, focusing on your career, and then you're like, oops, it's 40, I'm 44.
Exactly.
I would like children. I think that this is a godsend in many ways. And then for a woman, let's say, who is in her 50s or 60s, where her ovaries have, we've had this entropy, or we've had this decline, and now the adrenals have sort of taken over that sex hormone production, or just, the ovaries quit and then the adrenals just sort of keep puttering on. Is there any case studies or where we're seeing like 50 and 60-year-old women regain their menstrual cycle? And then I guess the follow-up question is, do we want that?
Yeah, exactly. That's what some people have said, do you really want to open this gate? So we do have some ideas on how we can do that. We haven't done that yet for someone that old. Not to say that's not that old necessarily, but that old when it comes to fertility.
Chronologically,
biologically. So it's something we are exploring, though, because we want to see how much can we extend the fertile years, exactly for the reason you said, because people are busier. There is, especially nowadays, with for a lot of women, they have to build their careers first, and then before you know it, you're considered geriatric when it comes to fertility, and you're told by your doctor that you're old. And then your first question would be like, well, is there anything I can do to make my body younger so I can get fertile and pregnant and in a safe way? And I believe you can. And I think because we understand so much more about the underlying mechanisms as to why this happens, we can target those mechanisms in a reliable way.
Yeah, I remember my second son, I was pregnant with him. I was 34, turning 35. And they're like, well, this is technically a geriatric pregnancy. And I was like, bite your tongue. I'm 34. Exactly. Yeah, I know. Yeah, exactly. But they classify, I understand why they do it, but just the name is so abrasive. So
I also think it's a little bit outdated, in my opinion, just because you could be 25 and have a 40-year-old's body, right? And that's
right. Exactly. So that's right.
I don't know anymore. Like, I don't know if necessarily that blanket statement works as they used to, because of the modern accelerated aging we're seeing in a lot of people with the modern environment.
Yeah, I saw J-Lo at the Super Bowl. Like, I know what 50 can look like. So yeah, that's what I'm gunning for. Okay, let's talk a little bit about, so you mentioned follistatin. I wanted to come back there because, again, when we have in that lowered sex, like that anabolic environment. So as we see estrogen lowering, testosterone lowering, both very anabolic for muscle tissue and preserving muscle tissue, tendons, ligaments, etc. What we often see in perimenopause, if the woman is not being strategic and she's not doing a lot of resistance training to either add to her mass and preserve her strength and her burst training, like those type 2 muscle fibers, is that, use it or lose it, right? I was a fitness instructor. That's how I paid for my schooling, actually. It was like, I was the step instructor and whatever. And it was always like, use it or lose it. Even if I had, stopped training or whatever it was for a couple of weeks and went back to the gym, I was like, oh my God, like it's really different. And that's only amplified when you're in your 40s and your 50s. So talk to us a little bit about follistatin gene therapy and how we might think about that in a woman who, and the women who are 40 and 50 now, just for some context, we all grew up, I'm 46. So we all grew up in that sort of high carb, low fat, cardio kind of environment in the 80s and 90s. So moving her to the gym, even though I'm doing my very best to educate, that there's still this very pervasive myth around getting bulky and I don't want to hurt myself and I don't even know what to do in the gym and that's for bros and it's like only meatheads there, etc. Because these women are going to be losing muscle tissue. They're going to become sarcopenic. How can we be thinking about the follistatin gene therapy that you were outlining as a maybe adjunct to, or maybe even some cases a replacement to the mechanical stimulus that we see? Or is it a viable alternative to the mechanical stimulus that you might see in the gym with lifting weights?
Yeah. Well, first off, I also worked as a gym instructor, so I come from that background as well. So that's why I have a unique lens, I guess, as a physician now. But follistatin is definitely the closest thing we have to an exercise in a pill or exercise in a syringe in this case. So what it does at a mechanistic level is it activates activin, which inhibits myostatin, and myostatin is an enzyme that sets a limit on how much muscle you can put on. So the higher your follistatin, the lower your myostatin. So it's called an antagonistic relationship. And the reason why we like that is because by taking the brakes off on what's setting a limit on your muscle is going to allow you to obviously put on muscle easier. But most importantly, I think for the average female, it's highly anti-catabolic. So meaning it will slow down muscle loss. One of the biggest reasons as to why you have increased muscle loss is actually the same reason. Oxidative stress and chronic inflammation are probably two of the biggest drivers. And the follistatin also activates something called FOXO3 pathway. And what that does is it upregulates T regulatory cells. And T regulatory cells are definitely my favorite cells in the body because Treg cells are so important for immunotolerance. And that immunotolerance is what gets disrupted as you get older and older. And then that's what leads to immune dysfunction and leads to that chronic inflammatory state known as inflammaging. And that's what follistatin does in a nutshell. And that's why it's so profound for females, because it's going to combat that inflammation. It's going to allow you to put on muscle easier, and it's going to prevent that muscle loss that comes with aging. And of course, it increases bone density as well, which we saw in the trials because we did DEXA scans on everyone. So osteopenia and osteoporosis is well known by the public, but doctors, for whatever reason, still are not recognizing sarcopenia. It's still not considered a disease, I don't think, and for whatever reason. But our phase 2 trial we're doing for follistatin is actually for sarcopenia. So that's a specific indication. We want it to be the world's first treatment for sarcopenia and hopefully get it covered by insurance companies down the road.
Oh, that would be so amazing. Awesome. Okay. Well, I have a question about that actually. So you were talking about, there's sort of this reciprocal, or maybe, as follistatin goes up, myostatin comes down. And myostatin being the sort of limiter, if you will, to the amount of muscle that you can put on. Is there another mechanism of action potentially in terms of increasing like satellite cells?
So you aren't necessarily increasing satellite cells, but you are increasing their ability to repair and regenerate tissue because you're reducing
the existing myocytes.
Yes, exactly. Because satellite cells are after you work out, there's micro tears, micro trauma that happens in the muscles, and then the satellite cells are responsible for helping the muscle to rebuild, and then over time it gets stronger and stronger, and that's what hypertrophy is, and that's why you have to do a progressive resistance training program and periodization, because your body adapts very quickly. So if you don't change things around, then your body just adapts and gets used to it, and it doesn't have the same stimulus anymore. So to progress and add muscle becomes easier because you also are able to recover and repair better because there's less inflammation.
And are there any contraindications to this therapy? How long does it last? How often should you get it?
Yeah, so one injection, it's subcutaneous or intramuscular. It literally takes 2 minutes and it lasts for 18 to 24 months. And it's essentially just the follistatin is going into your circulatory system and elevating the levels for that period of time. And the only contraindication would be we don't do it during pregnancy because we haven't studied it for that yet. So not during pregnancy. And that's pretty much it. So you can do it for any other case, including even cancer potentially, because we've done it for a few cancer patients just because they become cachectic and they lose so much muscle mass.
And how is an intramuscular? So you mentioned before that the therapy is quite specific, that you can sort of code for the, for the organ or tissue or gland that you're trying to develop. So how is this sounds more systemic. So it can be an intramuscular injection, and then you're getting the follistatin levels, I would assume, in the entire skeletal system are going to be elevated, correct?
Yeah. And follistatin is highly tissue specific. So it only acts on skeletal muscle. So it doesn't affect like cardiac muscle. So, and what it's doing is essentially, like, we inject let's say we do it into your deltoid. So that little tissue of deltoid muscle is now transformed with the plasmid vector. And what it's doing is it's telling the cell to produce more follistatin. And then that follistatin goes into the circulatory system. So then that's why it's not editing your genome. All it's doing is transforming that local site and telling that cell to give it a set of instructions. Similar to how the lipid nanoparticle vector with the mRNA is supposed to do. But unfortunately, the lipid nanoparticle vector is immunogenic, and there can be off-site targets. And we know that now. So if you can just read it, it's published out there. It's not, me making it up. So lipid nanoparticle vector is a vector that Moderna and Pfizer used. And the problem is that there's off-site targets and it's immunogenic. And that's why we see some weird side effects with the vaccine. And whereas with the plasmid vector, the mini circle vector that we have, it's non-immunogenic and there's no off-site targets. So at least we know we have that safety mechanism built into it, and we can feel confident we're not doing something we're not supposed to be doing. So there's an MD, PhD from some academic institution saying that this will kill you. I mean, which is just like obscene, because follistatin's been around for 20 years. It's not a new molecule. It's a naturally occurring peptide in your body. And once you understand the mechanism, which I think you do now in your audience, hopefully, we're not changing your DNA. All we're doing is just storing your peptides back to, and we already know peptides are relatively safe. So it's not like we're doing anything different than what's already out there. All we're doing is just changing the delivery mechanism so it actually stays in your body. But we can do that with any peptide. So we're gonna, or up to any protein up to 10,000 base pairs. So we're making one for Clotho. We're making one for luteinizing hormone, GHK. And then we're also gonna do CD19 CAR. So we're gonna make CAR T cells. And so we have a whole pipeline of products that we're gonna be making and really try to change the space and make this stuff more accessible.
So I was in private practice for about 16 years before retiring from private practice. And I always would, you would always hear things. So I'm a chiropractor. So you'd always hear like, oh my gosh, the neck adjustment kills you. And it's like, if that were true, I would be sweeping the dead bodies off of my stoop. Like, I was in practice for 16 years, not one adverse reaction, tens of thousands of neck adjustments, tens of thousands of all the other kind of articular manipulations that I would do. So I understand.
And think about how many people you help. This is such an overlooked issue by doctors still, and I don't understand it. There's something called number needed to harm versus number needed to treat, NNT. Yeah. And there's a great website called the NNT that looks at how much bad evidence there is for most pharmaceuticals. And it's basically like if you take even like a statin, for example, if you look at the number needed to treat, you actually need to treat over like 200 people to actually have a reduction in mortality. And then you take away, and then all the side effects of people who get myalgias and get, you deplete certain nutrients. And so you always have to look at the risk versus benefit. And to me, I like this space because peptides, even stem cells, and even now this plasmid vector, they all have very little risk. So there isn't at least harm that we're causing. And there's potential upside. So to me, it's always about what's going to have the least amount of harm and the most amount of benefit for the patient. And that's why if it was my own family member and they have osteoarthritis, unless it's really severe bone on bone and completely deformed, and I think, why wouldn't I try stem cells first? Because it's a reasonable option to do before surgery. And it's not like knee replacement surgery is 100% successful either. It's it's about 80% or 60% based on what data you look at. So and then there's a harm that goes with that too. There's complications, there's blood clots, there's the recovery that's way longer, there's the cost to the system. And so there's all these things that just baffle me. And it's almost painfully obvious now that the system is run by certain people and they want to keep it the way it is.
Yeah, it's like hidden in plain sight. Yeah. All right. So I feel like we are very aligned in some of our philosophical premises around healthcare. Let's talk a little bit about autoimmunity. Again, like Hashimoto's thyroiditis. I mean, there's like how many MS patients I've seen, lupus, but Hashi's.
It's increasing. I have a lot of physician friends who do kidney biopsies and do other type of work in the hospital. And they're saying they've seen so many more autoimmune conditions that they never saw before COVID.
Yeah. So how can we be thinking about stem cells as a medium for augmenting or at least because autoimmunity at its essence, I know that there's many different ways that it expresses itself, like RA or whatever. But at the end of the day, it's like there's that central tolerance that's lost, and we have these cells that are now attacking, that are ours, that are attacking us. So is there a way to restore that central tolerance? Is there a way to regulate? I don't know what the right word is here, but regulate the dysregulation.
Yes, exactly. So basically retrain the immune system is what I call it. So
great.
Basically, if you look at it go back to what's the root cause, most of your immune system's in your gut, and then the thymus gland is another important part of that. So the thymus gland is where your T cells go to become educated and kind of become adult form and learn what to do. And what happens as you age, after age 14 actually, is thymus involution or atrophy. And that's why there's been clinical trials looking at, is there things that we can do to keep the thymus gland preserved and prevent it from atrophying? And there has been some research suggesting growth hormone and peptides such as thymulin and bioregulators such as thymus extract can potentially help with that. So what we do is our autoimmune protocol, so to speak, which has been successful for treating many patients, is looking at the root cause of these two things. So we're not just using stem cells, we're also using peptides and bioregulators. So what we do is we try to prime the body for intravenous stem cells by reducing inflammation, by upregulating thymus function. So we use a bioregulator for thymus extract, and we use different peptides to reduce inflammation in the body.
Is that thyma beta? What is it? Alpha?
Thymus and alpha 1.
That's it, alpha 1, yeah.
And then we also use thymulin, which is another peptide to help with promote function of the thymus gland. And then because there has been, and this is a problem with clinical trials too, they always just look at one intervention, which is helpful. Obviously you need to isolate, but then the problem is, in reality, you can get a much more profound effect if you combine different therapies. Because there's also been clinical trials just looking at thymus extract, and patients have successfully been treated with psoriasis, with eczema, other autoimmune conditions like rheumatoid arthritis, even lupus. And that's just one intervention. And then the same thing with intravenous stem cells. There's trials showing inflammatory bowel disease, RA patients who've gone to remission just using with IV stem cells. But by combining them, obviously you're going to get a more profound effect. So we combine ours, and it's amplifying because they have different mechanisms, but they're synergistic. And so what the IV stem cells do is they're immunomodulatory. So they're helping to shift, like we were talking about earlier, that macrophage phenotype, and they're helping to shift permanently and retrain your immune system. And that's why patients can go into remission and have long-term results, because you're reducing that inflammation in the intestinal lining and helping to repair that intestinal permeability that we know is associated with autoimmunity. And this is very clear because people have gone into remission with just like carnivore diet or paleo, right? And that's a low
I've seen a lot of that, yeah.
Right, and that's so that right away tells you that methotrexate and drugs are not the only option. So there's obviously other means to an end here. And so for me, if you've tried the lifestyle stuff and it hasn't done it, then what's the next step after that? I don't think it should be methotrexate and those things. I think it should be this stuff because it's much less, it's not going to, again, no harm and a lot of potential upside. And it's also only getting better and better with the technology that we're using with peptides and with stem cells. And we also have FMT now. What we're going to have, we have our own FMT being manufactured, which is going to be ready in the spring. So that's fecal microbial transplant. We have lyophilized pills for that, which was basically help to repopulate the gut, because gut dysbiosis is also one of the hallmarks of aging, but obviously it's also intimately tied to autoimmunity.
So when we're thinking about treating, so let's just take Hashis as an example. So if we have Hashimoto's thyroiditis, we're thinking of treating this woman with stem cell therapy and maybe, I think you were mentioning some bioregulators and peptides. What would be, and obviously every patient's different, but what is the general cocktail or general sort of protocol that you might be thinking about with her?
It's pretty reproducible because there are more similarities than there is differences between autoimmune conditions. And that's not to say they're all the same, but the underlying dysfunctional processes are very similar. So whether it's MS or lupus, the underlying processes are similar. Now for MS, obviously you have lesions in the brain too. So we can even, there's a trial that was published just a month ago where they did stem cell injections directly into the brain, and it really dramatically helped their symptoms and helped put patients into remission as well. So we have a neurointerventional radiologist on our team who also injects stem cells directly into the brain. So sometimes we have to do that. But if it's just, let's just say like a standard autoimmune case like Hashimoto's, you don't have to do direct injections into the thyroid, although you can. We don't do that as a first step. The first step is usually the bioregulator, so the thymus extract, and then we use peptides, thymosin alpha-1, thymulin, BPC 157 for the gut, and to help with gut inflammation. And then we use intravenous stem cells, and we're usually using a fairly high dose. So the dosing is very important. The problem is this market, there's so many predatory clinics out there and in South America, and a lot of them just don't understand the science and they don't dose things properly, and if you underdose people, then obviously they're not going to get the right benefit either. So we make sure we do the right dosing. But the procedure is very easy. It's just an IV. You literally sit there for an hour or two, and then we have kind of the post-procedure protocol with a few peptides as well, like the ones I talked about earlier with BPC 157 and thymulin, thymosin alpha-1. And then you're basically trying to upregulate that thymus function. You're trying to reduce intestinal permeability. You're immunomodulating the entire body, and you're going to reduce that. You're going to increase that immunotolerance through those kind of synergistic approach.
And you mentioned underdosing with sort of non-regulated clinics or sort of pop-up shops. Can you overdo it? Can you overdose?
The worst case, like let's say you gave too many stem cells, you'll get an immune response and you may have a fever and headache and nausea for a couple of days, and then you'll be okay. So it's not really going to be disastrous if you overdose someone.
Okay. That's really good to know. And they're probably underdosing probably to cut costs as a pop-up shop might do. Right. Yeah.
The clinics in South America are notorious, and it's frustrating. And they're also not they're not interventionalists. Like I'm an interventional pain physician, sports doctor by training. And so you have to also, stem cells aren't magic in the sense that if you have a rotator cuff tear and you don't put things in the right place, they're not going to work.
Right.
They do have a homing ability to a certain extent, but you still have to have precision when it comes to this stuff. And that's why we do intra-arterial injections as well.
That's amazing. You mentioned clotho. I think I'm saying that right. Clothopeptide?
Yeah, clotho.
Clotho. Okay. Tell me about that.
Clotho is the coolest. I think it has over 3,000 PubMed studies on it now.
Is this a bioregulator?
It's a transmembrane peptide. So it's a large peptide.
Okay.
And it's basically the holy grail of, if follistatin is physical, clotho is mental. So meaning, we talked about how follistatin has all these amazing physical benefits, energy, strength, vitality. Clotho has nootropic cognitive enhancement benefits and potentially increasing IQ as well. So we're gonna track IQ during the trial, which we're starting in March. And we're also going to be looking at people's kidney function, because it can also help to reverse kidney disease as well. And then the clotho expression is low expression levels are associated with Alzheimer's, dementia, with chronic kidney disease. So we can also potentially inject it directly into the brain and into the kidney as well. So those are kind of the different applications. And it's also actually anti-cancerous. So you can also inject clotho directly into tumors. They've done that in animal studies where they injected clotho directly into the tumors, and then they were able to shrink like dramatically.
Well, that's cool, because coming back to perimenopause, like women will be like, I've walked into this room and I have no idea why.
Exactly.
The brain fog, the memory,
exactly.
Even just the changes in mood and affect are very.
And a lot of that is because your clotho levels decrease more as you age. And I'm sure I don't know if it probably hasn't been looked at specifically, but I have a feeling if you looked at females, I bet their levels decrease more dramatically than men.
Mm-hmm. Mm-hmm. I pulled up a little, because I was hoping that we might talk about this today. I just didn't know how to pronounce it. So, proteins that it also, I just have like a little thing from a synopsis from PubMed, and it said, growing evidence suggests that the FGF clotho endocrine system has a crucial role in the pathophysiology of age-related disorders, including diabetes, cancer, which you mentioned, atherosclerosis, and chronic kidney disease. So again, CVD. So just thinking about the development of cardiovascular disease, number one killer in women and men, but women always think, oh, it's breast cancer. That's the thing that's going to do me in. It's not. Not to say that there's no chance of ever getting breast cancer, but the number one killer of women still, it is cardiovascular disease. And I think, again, with the changes in our sex hormones, and there's this sort of phasic shift, but we tend to see CVD in women, 50s and 60s versus, in men, we start to see CVDs 40s and 50s, but it's that 10-year maybe phasic shift in.
And why is that, right? I think it's the same. It's basically, I keep coming back to it, but I really think it's the mitochondria, because what happens if you look at the most recent evidence as a CVD, it's not just ApoB. ApoB and LDL is part of it, obviously, to basically make the LDL cholesterol actually get stuck inside of the endothelial cells. But what
But the
is the trick?
LDL rises because of estrogen. Like it rises because we don't have we are in an estrogen deficient state.
Right.
Yeah.
But what causes the LDL to actually become plaque-like and cause that is the foam cells and everything.
The
So
infarction, yeah.
it's the mitochondrial. When you start getting mitochondrial damage, that leads to chemokines and inflammatory markers that are being released that tell the immune system to come in here and help fix this problem. But those immune cells are what causes the foam cells to form, and that's what causes unstable plaques and eventually leads to heart attacks. So it's coming back to that because there's just it's almost overly complicated. If you look at it at all the different mechanisms, it confuses people. But that's why if you try to simplify it back to, okay, what is really going on here? Can we restore the mitochondrial function and address that oxidative stress and chronic inflammation? Then we're going to get a lot more headway in terms of improving overall health. And that's why I come back to strength, because we know strength training and muscle is the best way to target those things. And that's why follistatin, let's just say follistatin, because some people are like, oh, how do you know follistatin's safe? Like aside from because we don't have like 20-year data on it, for example, like we don't have long-term data, but I'm very confident it's going to only have more benefits on mortality, because the longer you can preserve muscle and exercise and strength train, the better off you're going to be. So that's all. I just come back to the basics. Just look at how it's affecting your body from a holistic level. And that's the problem with a lot of scientists who are not clinicians. They get lost in the mechanisms, but they're not looking at the clinical application. We know that grip strength as a proxy measure is one of the best predictors of mortality, not just grip strength. So, and there's studies on myosteatosis, which is fat deposition in the glutes and in rec fem. Those are also predictors of mortality in COVID. So if we can help to preserve muscle through follistatin, we know we're doing more good than harm in the big picture.
Let's talk about cancer for a moment. I mentioned breast cancer. I would assume that stem cell therapy with the gene editing that you're talking about can also help deal with cancer. Can you speak, or I could be wrong, can you speak a little bit about if you've had patients clinically who are dealing with, I know that there's many different types of cancers, but maybe some successes there.
We have. Well, so this is something I learned in Japan. It's a different type of cell therapy, but it's just part of your innate immune system. So your innate immune system has something called natural killer cells and dendritic cells. And what happens, cancer is a very smart little bugger. And there's something called the cell suppression theory by Mark Lintron. And it's probably it is the most comprehensive theory on cancer because it explains all 10 hallmarks of cancer. And the theory is basically that there's a fungal spore or fungal organism that's part of the pathophysiology of cancer that hijacks the cell and suppresses cell function, preventing apoptosis. And this dysregulation over time is what leads to obviously uncontrolled growth and so many other things. So that's the gist of it. But he's obviously wrote a whole book on it. So if you really want to deep dive into what causing cancer, Mark Lintron's work is pretty groundbreaking, I would say, on this. And then so once you understand that there's a fungal organism involved in this, then it's kind of like, okay, why
That's
can't
wild that there's a fungal. I've never heard that there's a fungal organism.
Mm-hmm. Intracellular pathogen. Yeah, that's the root cause of cancer. So it's gotten a lot of headway now. I think a lot of oncologists are starting to buy, but again, it's probably going to take forever for mainstream medicine to hit it. But I think the people who are in the know what's going on, and that's why we're able to treat cancer now to a certain extent. And so what we're trying to do, because cancer is very smart, what happens is it becomes immunoevasive. So it figures out how to avoid your immune system. And so there are something called checkpoint inhibitors, which are approved by FDA for certain types of cancer, depending on the type you have, that can basically allow your immune system to detect it and actually target the cancer. So what we're doing is we're working on the other end, which is trying to boost your own immune system to fight the cancer. And so natural killer cell infusions are just a form of immunotherapy, which have been shown with chemotherapy to actually increase outcomes in terms of mortality. And it just essentially just arming your immune system with cells that can help to target the cancer. And the dendritic cells are antigen presenting cells. So they help to present the cancer cells to your immune system to target them. So that's why they work well together. So you can do natural killer cells and dendritic cell infusions for solid tumors. And then for hematological cancers, like lymphoma, leukemia, you can use something called CAR T, which is essentially chimeric antigen receptor on T cells. So T cells are the adaptive immune system, and then you can engineer them, gene edit them to add this antigen, which basically tells it, hey, this is where the cancer is, go kill it. So it's just arming your T cells to work better. And so it's all the same principle, which is essentially immunotherapy, getting your body to fight and recognize the cancer. And what we do, we work with the Dr. Tom Incledon in Arizona. He's a fantastic scientist who's been treating cancer for many years. And we work with him, and he has a protocol where he looks at micronutrients, looks at the mycotoxins, everything in the body that's preventing it from healing. And he does, and it's not like we don't do standard of care stuff. He works with the Mayo Clinic. So it's not like we tell people not to do chemo or radiation. It's just that there's things that we can
put
do.
on your tinfoil hat. Let's
yeah, exactly.
Yeah.
Yeah. So it's, and I mean, I'm not against that stuff. I just, if you look at the data, that stuff just doesn't work that well. And there's still so many people suffering and dying from cancer who just, I think, deserve access to these therapies. And all Dr. Tom does is just, again, looking at how do I get the body to try to heal itself? He uses something called EWOT, EWOT, exercise with oxygen therapy. And the oxygen helps to deprive cancer cells. And when you do exercise in the right dosing, it's a form of immunotherapy. It boosts your own natural killer cells and your T cells. How crazy is it that you can use exercise to kill cancer? Yeah. But if you understand how it's working, it does work. And we've had many patients who are stage 4 and still alive today. So it's not unreasonable. And I think it's only, with our next generation of therapeutics, like with Clotho, CAR T, I think we're going to have a whole armamentarium of cell therapy and gene therapy in combination with what he's doing to really help a lot of cancer patients.
Okay, so this might be a dumb question, but I'm going to ask it anyway. So you were talking about exercise as a mechanism for oxygen therapy. Is part of that also the sweating so that you are ridding yourself of the fungus?
Yes, exactly. It is. No, it's not a stupid question. Okay. When you exercise, and it activates hormone sensitive lipase, HSL, which is an enzyme that helps basically to mobilize fat and get rid of toxins from that fat. But that fat can only release those toxins when you sweat. If you're exercising, it doesn't happen when you do sauna, because HSL doesn't get activated. So
it has to be like a mechanism. It has to be like a mechanical stimulus, like you're running on the treadmill, or even like weightlifting, like a leg day. Like I'm soaked after leg day.
Exactly. Yeah, exactly. Yeah. If you've done a leg workout, you're always soaked after that. So, and if you don't sweat, you can get a sweatsuit. It's like $30 off Amazon. And you just wear that when you work out and make sure you're sweating a lot, because we're exposed to, so Mark Lintron, the cancer guy, he talks about, we're exposed to something like 200 fungal spores in our environment. So everyone gets exposed to it now. It's just a plague of modern environment. And so
it's the spore that's the...
Yes, it's intracellular pathogens. So there's different ones, but...
Oh, okay.
Yeah,
I have to read on this. I have a new topic to nerd out on my own time now.
Mark's a great guest. I think you would like to. He's fantastic. And
yes, please.
So basically, if your body is building up these toxins, obviously you have natural mechanisms to detox your body, but they do accumulate over time. And so the modern plague, yes, people talk about all these crazy detox programs and all this stuff, but honestly, just exercise and sweat. Like if you do that on a daily basis consistently, the toxins can't build up in your system. But most people don't sweat, and most people don't exercise enough. So of course we have this modern plague, and there's so many. It's not just even Alzheimer's, Parkinson's. These things have all been linked to fungal mechanisms as well. And one of the theories as to why statins work, just to come back to cardiovascular disease, is because it also has an antifungal component to it too, and anti-inflammatory. So it may not even be the cholesterol lowering mechanism that's having the mortality benefits. It may be the anti-inflammatory pathways that's what I believe. I think is the reason why statins are effective for certain people.
So at the end of this conversation, I'm just like, all right, sign me up. I want the follistatin. I want the whole thing. I want the anti-aging. I want the skin stuff.
Sure.
Like, I know we haven't talked about skin. I would like to actually move there if we can, just for a moment. Like a lot of women, at least I hear them sort of, we're marketed like skin creams, and we'll talk about GHK, maybe copper in this conversation as well. But I'm often asked, like, what do you do for your skin? What do you do for your hair? All this kind of stuff. Because I think that there's a certain maybe grieving that comes with aging as a woman because of the societal pressures that we're under. We always have to never look like we're a day over 24, so our hair is graying, and many women in menopause will also see their hair falling out. And then the face, like the loss of volume, particularly lower face. So there's there's the fillers and there's the Botox conversation maybe to be had here as well. But what can we think about in terms of stem cells for aesthetics? Like, face would be women are, thinking about putting their best face forward or whatever. I certainly am. I'm a vain woman. I'll put it out there.
No, so, I'm a vain guy too, I guess.
All right. Awesome.
So I always like to do the things on myself first and then we talk about them. So,
great.
But it's again, why does your skin cells start to age? It's not all that different from the other aging processes that we talked about. Yeah. The only other component to that is the elastin and the collagen that you lose and the fat that you lose. So fatty atrophy is, it's the one place where you want fat, because when you start losing fat in the skin, that obviously makes starts aging your skin. Mm-hmm. So, and that's where fat grafts come in and fat transfer, obviously. But what stem cells do and what we use now as well is we use those we use something called Yamanaka exosomes. And the reason we're using those is because they're from a skin biopsy. And so because they're from skin cells, they can help to stimulate fibroblasts, which help with collagen production. So we do a facial, we call it Eterna Glow because our company's called Eterna, and it helps your skin to actually glow, which is cool. But basically what it does is we're using stem cells, we're using those Yamanaka exosomes, and then we're also using radio frequency, which is heat. And that's all stimulating collagen production, but then it's also targeting those hallmarks of skin aging, oxidative stress, the senescence-associated secretory phenotype, the mitochondrial dysfunction, all the stuff, the same stuff that causes your skin cells to age is everywhere else in the body too. So we're just restoring and slowing down that process. It's obviously not going to be as dramatic as Botox or fillers, but it's also more preventative in a sense, and it's also more subtle and natural looking. So to me, as someone who's all about living longer, looking younger, and feeling better, that's part of it, is that I don't want to put toxins in my face that's just very temporary. And if you think about it, Botox is known to cause muscle atrophy. It's a known side effect. Yes. So what are you really doing to your face? You're in a cult, basically. You have to do it for the rest of your life. And then if you stop, which you eventually probably will, then you're going to have atrophy of muscles over time. So you're actually going to cause accelerated aging of your skin. So I just don't see it as a long-term solution. I get short-term, here and there, but it's for long-term, I think this is the way to go. And then on your note about copper peptide, there's been studies on GHK, your levels decrease as you age. So we know it's associated with decreased aging, and copper peptide is really important as it is more like a bioregulator for the skin, meaning it helps to improve skin function in general, but it also helps with oxidative stress, and it helps to promote collagen production and skin elasticity and skin youthfulness. So as you get older, your copper levels fall. So we're going to make a GHK gene therapy. So you just do one injection and you're good for 18 to 24 months, which I think will be our most popular product because everyone cares about cosmetics more than anything else. So,
for sure. But, yeah. But mostly I think I have a product that has copper in it. It's like a serum, like a topical serum.
The problem is most of them, the concentration is so low. So
I don't think mine passes the sniff test, if I'm being super honest.
We do have our own, which I'd love for you to come down to our clinic and try it. But we make our own cream with copper peptide. We use a compounding pharmacy though, and it has to be made in a pharmacy. And it's medical grade. It's 5% copper peptide, which I think is the highest I know of in the world. We combine it with coenzyme Q10 and hyaluronic acid. And again, the reason it's that combination is to target those different hallmarks of skin aging.
And so I had Dr. Tony Yoon on the show. He's a plastic surgeon. He's also a friend. And he was talking about loss of volume in the face. So he was talking about particularly in the lower. So I know that people typically do Botox like in the forehead and stuff. And I know that there's other applications. But he was talking about the lower half of the face typically losing volume. So like maybe it's because there's like resorption of the zygomatic arch and just like generally the mandible and all that. So some of the therapies that you're describing, are we going to be able to replace or stimulate the growth of the loss of, let's say, the bone resorption as well as the facial fat?
The fat and the muscle resorption.
The fat and the muscle resorption. Okay.
Can help with preventing and slowing that down, and actually even regrowing it potentially with the next generation of stem cell technology we have. So it'll be, I think that's definitely the way I think that's the way the cosmetic industry is going to go. Is going to be those minimally invasive procedures where you're replenishing the youthfulness of the skin using regenerative medicine. So on the note of Botox for, I guess if you're using Botox for this area, I mean, what was his proposal, I guess, for that?
Well, we were talking about the safety profile. Like he was like, this is the number, I think he said something like it is the most used procedure in the history of the earth, which I thought was incredible. He's like, you think that people are not on it, everybody's on it. And so he wasn't talking specifically about, we were talking about the forehead. I don't know if we were talking about specific protocols, but it was generally fillers and Botox, generally very safe. And he was talking about things like, I think he said threads. He's not a fan of threading because it doesn't last long and it's very expensive. So my question was really, I wanted to know about the safety profile because obviously I've heard about it and, kind of everybody's doing it. So I was interested in that, but I was also interested in for you specifically, the bone. Because one of the things we see, and this is kind of, I'm verging here to osteopenia, which is kind of coming back to what we were talking about with sarcopenia, but in the face and in the body as we age, there's that like those that osteoclastic to osteoblastic ratio tends to become, it's off, right? So we don't have more bone growth than we do resorption. So I'm wondering if some of the stem cells, if there's been any.
They do. They promote osteogenesis, and that's one of their mechanistic actions. Yeah. So that's one of the reasons why I think systemic treatments as well as injections can be helpful. And we can actually use bone marrow derived exosomes or stem cells as well if we want to specifically target, if that's the main reason you want to do it, for example. So you can
remind me, what is an exosome? I'm sorry, you mentioned that before.
Yes. So it's basically the soup that the stem cells grow in. So I would say if you have chicken soup, the chicken meat, that's the stem cells, and then the broth that it grows in is the exosomes. So it has all the nutrients, the growth factors, and the cytokines, which is really what we think is the main benefit of the stem cells anyway. It's called the secretome, which are kind of the molecules that get secreted from the stem cells that help with the benefits that you see.
Like it augments their efficacy.
But there's no actual stem cells in there because you don't necessarily need the actual stem cells depending on what you're trying to treat. If you're trying to immunomodulate, that's where really you would need the stem cells because they have a stronger immunomodulatory effect, but they work synergistically together as well. So that's often we're usually combining them.
Cool. And then so something like osteopenia, or it's, far more advanced version, osteoporosis, this is also something that we can be thinking about for the like for the scaffolding basically of the body.
Yeah,
right?
Exactly. Well, you can do bone marrow exosomes. So you can create, so these exosomes are derived from bone marrow, or you can have bone marrow stem cells. And obviously because the exosomes that are derived from bone marrow are going to have more specific effects on bone and targeting osteogenesis and increasing bone density.
Well, I'm coming to the Toronto clinic for the facial. And then if I wanted to do there's no stem cell therapy in Canada.
No, we can do the exosomes though. We can do the skin exosomes and the radio. Yeah, we can do the facial. Okay. And then we can also, because we're starting our phase 2 trial here for follistatin, we can do that as well. But for the stem cells, you have to travel, which you can come to Mexico or Dubai or Tokyo, the different places I work in, Switzerland.
I can do Mexico.
Yeah, exactly.
Mexico's very easy.
Yeah, it went from one of my scientific mentors who recently, Arnold Kaplan, he said it the best. He said the stem cell industry went from bench to business, but there should have been a middle ground there. So that's what we're trying to bridge that gap where, yes, obviously there's going to be a business component to this, but we also have a lot of scientific work we still need to do and tease out those details and do it in an ethical way where you're not exploiting people and being predatory about the marketing. So that's what we're trying to do. Yeah.
Wonderfully said. Well, I will make sure that all of the clinics in Dubai and Mexico and Canada and all the places that people can find you are in the show notes. Is there anywhere else that you would like to direct people?
Just our website, eterna.health. And if people, you can literally just click on there and book an appointment. So if you want to see us and want to talk to us, or if you're just suffering and need help, and we are also working on, because obviously these treatments aren't cheap. We are also working on a foundation, and we've done charitable cases for veterans and for people with disabilities. And that's one of the things I really want to build out over time, because there's so many people, and especially with chronic disabilities and veterans, they're just kind of forgotten about. And so if we can help them and raise awareness, I think that's one of the best things to kind of help everyone.
God, honestly, bless you. I used to do that in practice as well. I would always take on pro bonos, always I would take on vets. I would always have like people with chronic pain, the fibromyalgia patients that everyone was like,
because no one wants to see that. No one wants to help them.
Send her to the chiropractor. She's been on everything. Like, we don't want her anymore. And we always had those patients, and I would always treat them pro bono because it often was, they couldn't pay for the care. So Wonderfully said. Okay, wonderful. Thank you so much for your time, your focus, your energy, your dedication, and everything that you're doing to move your career and your field of study forward. Just very, hat tip to you. This has been a wonderful conversation.
Thank you.